Good evening, all. We welcome you to this unique presentation by MAHAIAP, Friday Ka Punch, MAHAIAP Ke Sang, wherein the daily topics of prime importance of daily office practice ones which we should not miss are carried out. The topic in focus today is pediatric endocrinology in office practice. Yes, the brainchild of our president Park Sir and our secretary Amol Pawar sir. I would like to request our president Park Sir to kindly address all the delegates and the faculties as well. Over to you, sir.
So good evening all. Namaskar. After the Mahapedicon just 5 days back, where we were means a very good scientific fest of Mahapedicon. Again, we are starting our MAHAIP programs, which we are doing every month, 5 to 6 webinars, out of which is Friday Ka Panch MAHAIP Ka Sang. This webinar is definitely a good initiative because it covers all the regions of the Maharashtra, all the 5 regions of the Maharashtra. And the speakers are generally the young people who are the budding and growing means who are coming in the clinical practice or joined the institute. And with the experts like Tushar Godbole sir and R. Hari. And so overall, it is a program for the means young guns, where we can see their talents and as well as inspire the other people to come on this particular platform and show their talent also. So topic chosen are generally very means usual and routine topics which do help in our clinical practice, because in the very short time we have to diagnose the thing as well as do the rational way with justice to the patients. So for this we need some inputs, and let us hear from our today's presenters what the inputs are giving, and after which our experts will tell us give their special comments. So I welcome Dr. Amol Pawar, our dynamic secretary of MAHAIP, then Sachin, MAHAIP EB, and all the other OBs and EBs. Yes, again one of the EB of MAHAIP, and other members who have joined for the particular today's program. I welcome you all, and let us start with our presentations and expert comments, because at 9 o'clock again we have to join for some other program. So over to you, Ash.
Thank you, sir. Thank you for the warm welcome and giving the brief purview of this meet. Here on, I would like to request our dynamic secretary Amol Pawar sir to kindly enlighten and guide the gathering here.
Thank you, Yash. First of all, a warm welcome to all the Maharashtra IP members, delegates, PG students, and both our experts, Dr. Tushar and Dr. Hari sir, and also all the 5 speakers, Dr. Tejas, Dr. Bhushan, then Dr. Ajinkya, Dr. Madhura, and Dr. Sushil. Dr. Vijay Ole sir's son, a young pediatric endocrinologist in Navi Mumbai, and all the Dr. Sanjay sir, Dr. Meena sir, then both our moderators, Dr. Yash and Dr. Harshal, well guided by Dr. Sachin Patil. Actually, Sachin has taken a lot of efforts in coordinating almost this is the 9th webinar, and all the Maharashtra IP office bearers, presidents, secretaries, they have helped, and they have given all the speakers from their zones for all the 9 webinars, and again 2 more webinars we'll be doing in November and December respectively. So endocrinology, as we know, this is very vast subject, and there is a long list of learned endocrinologists for guiding us. They are spread across all over Maharashtra, and Maharashtra pediatricians, Maharashtra IP members are there. Very fortunate to have so many learned endocrinologists, be it Pune, Mumbai, Navi Mumbai, Nagpur, or Nashik, or all means all the metro cities. They have many of them are there, and they are always guiding to all the pediatricians to diagnose the difficult cases in endocrinology. So both experts will have many things to say, many things, many inputs they will be giving to all the young speakers as well as all the delegates as well. So wish you all happy learning, and please continue, Yash and Harshal. All the best to you and all the best to all the five speakers. Thank you.
Thank you,
Thank you,
sir.
sir.
Now
So,
I request Dr. Minaj sir to say a few words before we start the
Oh,
proceedings.
thank you, Harshal. Thank you, President Sir, Dr. Sanjay, Amul Pawar, our secretary, and the entire team. We'll continue with this activity. In fact, we have been blessed that we are continuing this activity throughout the year and will continue the next 2 months also. We are sincerely thankful to all our speakers who have consented and our expert for being the part of this session. Thank you all, and over to you, Harshal and Yash.
One more request from Maharashtra IIP office and Maharashtra IIP team. We have elections starting from 22nd to 29th of October. So there are many candidates from Maharashtra. So please vote and see to it that all your branch members vote for right candidates. Thank you.
Thank you, sir. So moving on with the today's session, I would briefly introduce our two experts, the endocrinologist from Nashik. He is director at Harmony Hub Hospital, Nashik. He is associate professor at Vasantrao Pawar College, Nashik, as well as visiting consultant at Dhude and Sambhajinagar. Along with him, we have Dr. Harim Mangtani, sir. He is pediatric endocrinologist at Nagpur. Regarding our five speakers, we have Dr. Tejas Deshmukh, sir. He has done fellowship in neonatology, and he is neonatal and pediatric intensivist at Niramaya Pediatric Hospital, Nanded. We have Dr. Madhura Kargupikar, madam. She is also a pediatric endocrinologist from Pune, and she is a consultant pediatric endocrinologist at Jupiter Hospital, Pune, Dinanath Mangeshkar Hospital, as well as Sahyadri Hospital. Our third speaker, Dr. Bhushan Torat. I know him since long time. He's a pediatric endocrinologist right now practicing in Amravati, and he's my father's PG student. Along with him, we have Dr. Ajinkya Patil, sir. He's a pediatric endocrinologist from Jalgaon, and he is also assistant professor in medical college in Jalgaon, and he is a founder of Club 1, that is Type 1 Diabetes Charitable Foundation at Jalgaon. And we also have Dr. Sushi, is a pediatric endocrinologist from Navi Mumbai. So with this, I request Dr. Yash to begin with the further proceedings.
yes, as we move on to the real case summaries. So, the earliest preventable cause of mental retardation can be said as hypothyroidism. So, how to screen the congenital hypothyroidism? For it, we have with us Dr. Tejas Deshmukh, who would be helping us go through and early signs to pick up. As said earlier, Dr. Tejas is a consultant neonatal and pediatric intensivist at Niramaya Hospital, Nanded. Over to you, sir.
Thank you, sir. Thank you, Pakmode, sir. Yes, sir. Amol Pawar, sir, Sachin Patil, sir, and all the office bearers of the MAHAIP to giving me this opportunity to share something about the screening for congenital hypothyroidism. Thank you. So, as such, this topic looks very easy, but yeah, but in depth, it has much more to it. So I would like to begin with some neonatal thyroid physiology. Firstly, there is thyrotropin releasing hormone secretes from the hypothalamus, which stimulates the pituitary to secrete TSH, and in turn, that again stimulates the thyroid gland to secrete T4 and T3 hormone, and thus this is continuously feedback axis is running, and into the in utero life, maternal T4 uh, provides limited fetal protection until birth, and then the fetal thyroid glands take over for the production of T4 and T3. And another interesting fact is that postnatal TSS surge peaks at the 30 to 60 minutes of life, and that axis stabilizes within the first week. So after that, we have to look into the epidemiology and its significance for the screening. In the worldwide scenario, the congenital hypothyroidism incidence is from 500, 1 in 500 to 1 in 5,000. So it's varies according to the region. And in India, and in particularly non-endemic regions, it affects about 1 in 1031 term neonates. And from endemic region, 1 in every 13 term uh, neonates, and 1 in 20 neonates born to mothers with thyroid disorder. And if we consider the case of preterm neonates, then 1 in every 71 preterm neonates affected with the congenital hypothyroidism. And uh, what uh, what is there? We will recall the patient for the confirmatory testing if the that screening comes positive, but all will not come, and we add that loss to follow-up cases, the estimated prevalence is 20% higher than 1 in 1031 cases. Yes, next slide please. This I have already explained. Next slide please. Then what is the rationale for screening? The clinical signs often absent at birth, and biochemical detection will only provide us the clue about the presence of hypothyroidism, because it is the, as yes sir rightly said, it is the most common preventable cause of intellectual disability. Delayed detection leads to irreversible neurodevelopmental damage, and it is very much cost effective. So screening cost is much lesser than the cost of lifelong disability. If we pick that mental retardation and delayed milestones at 6 months, 1 year, 2 years of age, then already we have lost much more time. And as we all know, the 95% of the cortex development will occur till the age of 4 years. And it is also, the screening is also supported by WHO, IAP, and AAP as standard newborn screening practice. Next slide, please. Then what is the screening protocol? Screening protocol is that we have to ideally take sample between 48 to 72 hours of life. And what type of sample? There is heel prick dried blood spot on filter paper, that is called as Guthrie card, because the Dr. Guthrie has invented that card. He was authority on phenyl ketonuria in the US. For that, he has invented that card, but now it is used worldwide for the transport of sample because it's so simple. And what we will detect in that sample, that either we can detect TSH levels, then primary T4 with reflect TSH levels, and we can do both TSH as well as T4 levels. But in country like us, developing country, we will prefer TSH level only. Yeah. And if the first, we will do this newborn screening by DBS for all the neonates. And if the first NBS is the newborn screen is normal, perform a second NBS at 2 to 4 weeks of age or 36 corrected weeks of gestation. In the newborns who are preterm, less than 32 weeks of gestation, who are acutely ill, which were admitted in NICU, have very low birth weight, less than 1.5 kg, and received a blood transfusion before obtaining the newborn screening sample. And in case of monozygotic twins or multiple births, and those who are having Down syndrome, trisomy 20. And in case of any abnormal phases, syndromic phases, we can also do the repeat NBS, second NBS. Next slide, please. Then what is about the laboratory workflow and cutoffs? First, we will uh, collect the sample in 48 to 72 hours after birth, and then we will transport that card, that DBS card, to the lab. And if we suspect that neonate is going to discharge within the first 24 hours, in that case, we will collect the cord specimen, cord blood, and we will send that. And cutoff levels vary by lab to lab, and if the values come in the borderline area, then we have to retest it by the serum values and not by the DBS values. And we have to consider age specific and method specific reference values, because serum values concentration are different and DBS concentrations are different. And above first week of life, above first month of life, values are different. Next slide, please. Then if there is high TSH and low T4 level, then we can consider as a primary CH. And if there is low TSH and low T4, then there is central CH, because there is absence of or dysgenesis of thyroid gland. In case of borderline TSH, we have to repeat screen, or we can send the serum confirmation by recall of the newborn. Then we have to follow structure uh, algorithm. If any kind of abnormality in the TSH result, borderline result, in case of failed sample, incorrect sample, we have to again confirm. And on confirmation, if we are sure that this is hypothyroidism, we can treat it. Yeah. Next slide, please. According to IAP 2021 guidelines, same is there, that sample collection ideally at 48 to 72 hours of life. Primary TSH strategy preferred is TSH value more than 20. On DBS require recall, and immediate confirmatory serum testing is recommended. And early initiation of treatment emphasized to prevent neurodevelopmental delay. Yes. Next slide, please.
So can we
And there
just
is
sum up to the important slides as well? The time is exceeding. The
yeah.
time limit.
Yeah, some of the last slides. Yeah, and according to AAP 2023 update, those are if the NPS TSH is more than 40, then straight away they recommended to start treatment, and the after drawing the confirmatory serum sample, and if it is less than 40, then we have to await the result for the repeat sample, and hold off on starting T4 treatment. Next slide, please. So it, in that way, in case if NVS thyroid tests are normal and we have the clinical signs and symptoms suggestive of CS, such as large posterior fontanelle, large tongue, umbilical hernia, prolonged jaundice, constipation, lethargy, and hypothermia, we can start the treatment to see any improvement in the symptoms. Yeah. So I think, yeah. So only three states are there: Chandigarh, Kerala, and Goa. They are conducting the screening for the CH, and or all other states have to follow that. The major challenges in India is sample transport, quality assurance, and rural coverage of the screening. Next slide, please. So that CH is a preventable cause of intellectual disability. Universal screening is essential for early diagnosis. We have to follow the structural approach, algorithmic approach, screen, confirm, treat, and monitor, adhere to updated IAP and AAP guidelines for best outcomes. Thank you.
Thank you, sir. I request Sachin sir, Sachin Patil sir, to take over and take a few questions or comments from the moderators. Sachin Patil sir.
Sorry, I won't able to take questions.
Sure. So, any comments from the moderators, the experts present? Hari sir.
So, congratulations, Dr. Tejas, for the wonderful presentation. The most important takeaway, I would say that every time we keep on discussing the cutoffs, the levels, and everything. But the most important thing, takeaway, I would say, is screening everyone is important. Not only kids of the hypothyroid mother or mother having some thyroid disorder. Every newborn should be screened as early as possible. Then when you have screened, the cutoffs can be variable, they are different, and you can actually approach your friends, your pediatric endocrinologist friend, just to verify what needs to be done. Okay. But if you get only one chance to do it, please do it whenever you get a chance.
Point well taken, sir. I would also request a brief comment from Dr. Tushar Godbole, sir.
Yeah, very well presented. Just a quick comment that we have our own guidelines in place now. The Indian Academy of Pediatrics has already endorsed the ISPE guidelines. So I'll urge all of you to visit the ISPE, the Indian Society for Pediatric Adolescent Endocrinology website. And there is a very nice publication that had come out in 2021, if I remember, that gives out the flowchart nicely. So ISPE guideline for newborn screening for congenital hypothyroid. I'll urge all of you to follow that guideline. Thank you.
Thank you, sir.
Thank you, sir. So, yes, point very well taken that not to leave any hypothyroidism on ease, and we should not miss it. So, as we move on to the next topic and the next speaker, uh, hypoglycemia, the one which we live for, the sugar rush. So, critical sampling in hypoglycemia. So, for it, we have with us Dr. Bhushan Thorat, sir. He is an endocrinologist working in Amravati, and he would be guiding us through the major critical aspects which can be handed over. Over to you, sir.
Good evening, everyone. Thank you very much for providing me the opportunity to present a case on a critical sampling in hypoglycemia. There is a time constraint. I will start as early as possible. I have shared my PPT to WhatsApp group because there is a sharing problem on this Zoom. Can you please share via group in the WhatsApp? Okay. First slide. Next slide. And this learning objective will be the understand the rationale for the critical sampling, know the priority wise tests to be collected, learn to handling and transport requirement, interpret the lab results logically, and apply the clinical approach for the diagnosis and management. Next slide. You can say why the critical sampling matters. Actually, it defines the etiology of hypoglycemia precisely. Uh, it must be collected during the hypoglycemia. It prevent the misdiagnosis of the hyperinsulinism or the any metabolic cause. The diagnostic yield highest when we take it before the glucose correction. Next slide. Next slide, sir. Uh, we'll go to the definition of the critical sampling. Critical sampling is what when blood and urine collected at the time of documented hypoglycemia. Previous slide, sir. I have not finished it. Previous slide. What is the critical sampling? The sir previous next slide. Definition slide. Yes. Okay. 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 What is critical sampling? When we collect the blood and urine at a time of documented hypoglycemia before we give the dextrose or glucagon, it captures the biochemical snapshot that differentiate hyperinsulinism, endocrine deficiency, fatty acid oxidation defect, or gluconeogenetic defect. Next slide. When to collect the sample? Yeah, there are the cutoffs we will discuss. In the neonate, it is a 45 milligram per deciliter. In infant or child, 50 milligram per deciliter. In adolescent, 55 milligram per deciliter. We should collect immediately during the symptomatic hypoglycemia. If the dextrose is life-saving, we can draw the sample first as much as we can, or we can do it simultaneously also. Next slide. There are the multiple taste sampling. We are dividing that sampling in the two levels, that is level 1 or level 2, because there are a number of diagnoses can be clinched from these tests, but some commoner tests and some the level 1, but they are the essential for the all cases. In the level 1, I have included 8 tests. The first is plasma glucose, that should be the lab confirmed. Then it is the priority wise test. These are the priority wise tests. Second is insulin and C peptide. Third is hydroxybutyrate, that is ketone. Free fatty acid, cortisol, lactate, ammonia, urinary ketone. These it define the basic biochemical pattern. Next slide. These are the level 2. If the facilities is available, or if we are suspecting some another diseases, another syndromes, we can also send the following tests like growth hormone. When we can see there any neonate having the micropenis, prolonged jaundice, any central defect, we can suspect it can be the growth hormone deficiency. So the growth hormone the test, which could be the can clinch the diagnosis in that case. Plasma acyl carnitine profile. If we are suspecting fatty acid oxygen defect, the plasma acyl carnitine can provide a diagnosis. Plasma amino acids, gluconeogenetic defect, urinary organic acid, sulfonylurea screen, or anyway, we can see the liver enzyme, electrolyte, and ABG can be the in a hepatopathy. These tests can be the second line or the level 2 if the facilities are available. If we are suspecting another cause in that case. Next slide. It is the very important how to handle the sample and how to transport it. If you are not doing this well, the reports can change, diagnosis can change. Uh, I will say we insulin and C peptide should be chilled separate and freeze under minus 20 degrees Celsius. When you collect the ammonia, it should collect on ice and it's separate within 15 minutes. For the lactate, no tourniquet should be used. It should be collected on ice. Acyl carnitine or amino acid should be freeze or right blood spots. We should document the time, bedside glucose, last feed, and medications. While we draw the sample, this should be the documentation should be the clear regarding the time, bedside glucose, last feed, and medication. Next slide. There is a stepwise approach for the hypoglycemia evaluation. We should first confirm the low plasma glucose. We should draw critical sample. We have to interpret insulin, beta hydroxybutyrate, free fatty acid pattern. We can add to that cortisol level, lactate, ammonia for the metabolic or the endocrine differentiation. And we can confirm in the advanced test or genetics if there is a recurrent episodes. Next slide. We will interpret accordingly, and I will discuss the pattern recognition. Whenever there is a pattern, when there is an increase in insulin, the maximum causes when we see the decrease in insulin. But first, we have to define the insulin level. If there is an increase in the insulin level and a decrease in the ketone and a decrease in the free fatty acid, we should suspect hyperinsulinism. The next, when there is a decrease in insulin, decrease in ketone, and decrease in the free fatty acids. So previous slide. When there is a decrease in insulin, decrease in the ketone, decrease in the free fatty acid, we can suspect the free fatty acid oxidation defect. When there is a decrease in insulin, increase in the ketone, increase in the free fatty acid, there can be an endocrine deficiency or ketotic hypoglycemia. And when we see when there is a decrease in insulin and increase in the lactate or increase in the ammonia, we can suspect the organic acidemia. This in the pattern recognition is very important. It is very easy also. We can identify according to this, and we can do the advanced test after also. Quantitative interpretation. When the insulin is more than 2 to 3 microunit per ml during the hypoglycemia, it is always inappropriate. If it is more than 2 to 3 microunit per ml, we can suspect hypoglycemia. C-peptide is always increase in the endogenous insulin and it is decrease in the exogenous insulin. When we administer the insulin exogenously, the C-peptide is the lower side. Beta hydroxybutyrate less than 0.6 millimole, it suggests the suppressed ketogenesis. When the free fatty acids less than 0.5 millimole per liter, it shows the suppressed lipolysis. When the ammonia is more than 100 micromole per liter, it suggests metabolic defect. When the lactate is more than 3 millimole per liter, it suggests the gluconeogenic block. Next slide. It suggests the algorithmic approach. We have to confirm the low glucose. When there is a low glucose, we should check the first insulin. If insulin high, it is hyperinsulinism. If insulin is low, we have to check beta hydroxybutyrate and free fatty acid. The both are the low, then it is a free fatty oxidation defect. If the both are high, we can suspect the endocrine cause. But if it is associated with the increase in the lactate or ammonia, it is the metabolic defect. Next slide. We will shortly discuss the major causes. Whether it is the approach to hyperinsulinism, there is a finding means that there is a insulin is detectable during hypoglycemia. The ketones are the low, free fatty acids are the low. The next step is to exclude exogenous insulin by documenting the C-peptide layer, excluding the sulfonylurea. We can consider congenital hyperinsulinism by sending the genetic studies. We can try dioxide or consider imaging.
Dr. Bhushan, I'm sorry to interrupt you. Can we limit your discussion here? I mean, we are running short of time, and I think
Yes,
this
yes,
is
yes.
Yeah, I
we
can
need
have it
to.
on bullet points. Yes.
Yeah.
Yes, sir.
I mean, let's stick to the critical sampling only.
Okay, sir. Okay, sir. Okay, sir.
I'll be
Next
happy
slide.
if you tell about ketones. Yeah.
Okay, okay, sir. Next slides. Next slide. Um, Next slide. We will skip this slide because discussion is it taking the time.
And
Next,
come directly to the conclusion slide.
next slide. Next slide. Next slide. We will We have skipped the multiple slides. We share the common pitfalls in this topic. Uh, Common pitfalls. Previous slide. Previous slide. Previous slide. Previous slide. Uh, Common pitfall in this next slide sir. pitfall वाली slide चालू रखिए. हाँ बस. Okay, okay. Common pitfall in this doing the sampling after the glucose correction, improper sample chilling, missing the documentation of timing, assuming no ketones, and delayed processing. Delayed processing leads to the false negative. Next slide, sir. We will shortly discuss the clinical one. When there is a detectable insulin and low ketone, it is hyperinsulinism. When there is a low ketone and high ammonia, it is fatty acid oxidation defect. When there is a low ketone and high lactate, it can be the gluconeogenetic defect. Remember, the right sample, right time is equal to right diagnosis. Next slide, sir. I'm concluding after next slide. Key takeaways: the draw sample before the correction, prioritize insulin, beta hydroxybutyrate, fatty acid, cortisol, lactate, and ammonia. Handle and document meticulously. Interpret the pattern, not isolated values. Prepare the hypoglycemic critical sample in all units. Thank you. I'm finishing my discussion. Thank you very much.
Thank you, sir. Definitely, you try to cover the topic in detail, but we'll have just one comment from Tushar sir and one comment from Hari sir.
Yeah. Indeed, it's a very vast topic, and we wanted to restrict only to the critical sampling part. Um, so, a practical tip from my side would be all of us who are working in ICUs should have a point of care blood ketone meter, because often when we send the critical samples, if you are looking for beta hydroxybutyrate, especially the blood ketones, typically the report would come on the next day and it's of no use. So if you have a bedside blood ketone meter, which is easily available, you can straight away divide the causes of hypoglycemia into non-ketotic the ketone
Probably we have some network issues. I would like to request Hari Mangtani sir to kindly take over.
What I would tell very practical, which I have seen over a period of years, if you have missed collecting or your the doctor in ICU has missed it or sister has missed it, pushed the dextrose, please collect the first urine sample, first urine void, post hypoglycemia, check ketones. That also fairly gives you a good idea. And of course, the clinical history and detailed examination, it definitely clinches the diagnosis. If you get a metabolic catabolic state where there is acidosis, there is it suggests towards metabolic problem. But if you have high GDR, then it is probably towards hyperinsulinism. And if the hypoglycemia is not associated with both of it and gets corrected easily with a low glucose delivery rate, then we are perhaps looking out for a endocrine cause. That's it.
We have Tushar sir back. Just concluding remarks, sir, for this segment. Tushar sir. Okay, probably the
So
network
I
issues.
think sorry, I have a
Yeah, the network
network
issue
issue. So I was
continues.
mentioning
Yes.
about the blood ketones. Yep. And
Please continue, sir.
the chore has to be picked up range हाथ. So चोर को रंगे हाथ पकड़ना है, तो please pediatricians should remember to collect critical sample. That's most.
Thank you, sir. Thank you, Bhushan sir. Well, as we head on to the next topic, obesity, which is the evolving pandemic and a matter of concern both for adults and young. We have for this none other than Dr. Madhura from Pune, working at various hospitals and giving her expert expert inputs. So, without much ado, over to you, Dr. Madhura, please.
Thank you. Am I audible?
Yeah, very well.
And the slides
The
just
slides are visible as well.
great. So we'll start with a short case scenario. This is a 9-year, 8-month-old girl I saw for obesity, onset of weight gain from about 5 years of age, and there is history of nocturnal awakening to pass urine every night. Also, there is increased urine frequency during the day, and there is polyphagia. Weight of 72.4, height of 143.8, and BMI is clearly in the obese range, 35.4. On evaluating the history, her diet was very rich in carbohydrates, fats, and energy dense foods. Father worked at a Chinese restaurant, and that's why every day there were parcels of Chinese food coming in, which were high in fat and energy. There was large portion size and a lot of snacking. Uh, she had a lot of screen time that was non-academic, so more than 3 hours of screen time. Birth weight was okay. She used to sleep very late once the father came back home, and grandfather had a history of type 2 diabetes, early onset at 46 years of age. Further on history, there was shortness of breath and exercise intolerance noted. Mother said that she used to snore at night and also had daytime sleepiness. As I already mentioned, there was polyuria, polydipsia, pointing towards diabetes. Plotting her on the chart, she was tall and obese, and on the BMI chart, she was clearly in the class 3 obesity. So, this is a tall and obese child pointing towards exogenous or nutritional obesity. A short and obese child would be more sinister, and it would be an endocrine or a genetic or syndromic cause. BMI is a flawed parameter as such, because it does not consider, the bone density, the muscle mass, nothing else. It's just a weight that is considered. And hence, waist circumference gives a better idea. And in this girl, the waist circumference was above the 70th percentile, so there was central adiposity. Now, this is a very exhaustive list of what we should try to look at in clinical examination or in clinical clues. We will not go through this list, but just to look at a few clinical pictures for us to remember. So, clinical clues in obesity for nutritional obesity or metabolic syndrome. In boys, lipomastia. Even in girls who are prepubertal, there could be lipomastia. Acanthosis and skin tags, and buried penis is a very common complaint coming to the OPD with small penis. Actually, it's a buried penis due to obesity. So the problem is obesity, not the small penis. Clinical clues for endocrine causes in obesity. There could be abdominal striae, moon phase, buffalo hump, hypertension pointing towards Cushing's. Short stature, dry skin, bradycardia, and constipation pointing towards hypothyroidism. So look for these clues. Then coming to syndromic obesity, we could look for polydactyly and eye defects pointing towards Bardet-Biedl syndrome. Microcephaly, dysmorphism pointing towards so many syndromes. One of them is Alstrom. This was a case of Alstrom syndrome. Clinical clues in syndromic obesity, further genetic obesity. So look for other siblings or the father or the mother having a similar pattern of obesity. Here, this was a family on the left with MC4R mutation. And on the right is a child with Prader-Willi. She had early onset obesity, hyperphagia, skin picking, and developmental delay. Next, coming to more syndromic causes, these, as we can see in the clinical pictures here, there are short fingers and short toes, and the child had developmental delay along with small for gestational age. The child was born. This is Albright's osteodystrophy, which is also pseudo hypoparathyroidism or hypoparathyroidism. So these are the clinical markers that we should look for in obesity. Coming to the biochemical tests, blood pressure to look for hypertension, snoring or polysomnography for obstructive sleep apnea, hirsutism, irregular menses for PCOS, a psychological assessment, fasting PP sugars for diabetes along with HbA1c, SGPT, and ultrasound abdomen for fatty liver, fasting lipid profile for dyslipidemia, and thyroid profile. These are the basic tests that we should look at depending on case to case basis. Now, coming back to this child, her blood pressure was hypertensive for her age. She had severe acanthosis, lipomastia, and genu valgum. Fasting PP sugars, HbA1c pointed towards diabetes. Lipid profile was deranged. SGPT was high, and ultrasound showed fatty liver. So, to summarize, this was a tall and obese girl with early onset obesity, faulty lifestyle, developmentally all right, with type 2 diabetes, dyslipidemia, fatty liver. So, this was a case of pediatric metabolic syndrome secondary to exogenous or nutritional obesity, which is the most common cause of obesity. In 90% of the cases, the cause is nutritional obesity. Coming to the last bit where there are red flags for pathological obesity, where we should be very concerned. Uh, First is a very rapid onset of weight gain in the first few years of life, especially in the first year of life. Short stature for age and for mid-parental height. Hyperphagia, that is, the child eats a lot. Dysmorphism, other associated features of developmental delay, vision abnormalities, and behavioral issues. History of any steroid intake, and hypogonadism. Thank you. I hope I
Thank
finished in time.
very well, means absolutely in time, and the lecture was well in detail.
Thank you.
Uh, can we have some inputs from Dr. Hari Mangtani, sir?
Very well presented, Madhura.
Thank you, sir.
And she actually covered almost everything, every aspect of it. The most important aspect is unless it is proved otherwise, most of the obesity are exogenous obesities, and we should actually counsel mothers since very early and during every immunization. We should try to counsel the parents about healthy feeding, healthy eating habits, and healthy lifestyle. Very difficult, but yes, they have to understand one fine day. Everyone has to understand this because the it is increasing very rapidly. The obesity is increasing very rapidly, and the complications are really very high, as seen in case we had such a small child with type 2 diabetes.
Thank you, sir.
Uh, can I request Tushar, sir,
Yes.
to kindly contribute?
Yeah. Excellent presentation, Dr. Madhura.
Thank you.
May I know what was the age of that patient?
Which one, sir?
The case that you showed.
9 years and 8 months, sir.
So, if rather it's a alarming sign and a warning sign for all
Absolutely.
pediatricians that don't assume that 9-year-olds don't have diabetes. In fact, this is what all of us are seeing in a day-to-day practice, that children as young as 8 and 9 are coming to us with obesity and type 2 diabetes.
Great.
So if the patient is not coming to you with fasting state, just do a random sugar also. Sometimes a random sugar will also pick up at least pre-diabetes. Second is blood pressure. I have seen many of us do not check blood pressure for children below 10 years. So I'll urge all of you to check for hypertension and SGPT, because it's a marker for steatohepatitis. It's a very good biochemical tool to stress upon the family that the future could be liver cirrhosis if you don't reduce the weight right now. So excellent presentation, Dr. Madhura.
Thanks again, sir. Thank you.
Exactly.
So moving
Yeah, there was one more
ahead
question in the chat
with the
box.
next
Just
talk.
before we
Sorry.
move on ahead, there was one question that how maternal hypothyroidism has an effect on neonatal thyroid status. So, just before we proceed to the next talk, I would like a brief comment from Dr. Tushar, please.
So the etiology was already mentioned by the first speaker, that most of the congenital hypothyroid is in fact dysgenesis. It's not genetic. So it's just like having 6 fingers of cleft lip or some. It's a birth defect, nothing to do with maternal hypothyroid. If you screen babies born to maternal hypothyroid, only 2% of those will have elevated TSH. On the other hand, if you are screening babies born to Graves' disease, that is hyperthyroid, you can have a mixed picture, either hyper or hypothyroid. So regardless of maternal, I'll again want to stress this fact that regardless of maternal thyroid status, please screen all neonates for congenital hypothyroid.
Thank you, sir. I would like to request Dr. Harshal, sir, to kindly take over the further proceedings.
I would now invite Dr. Ajinkya Patil, sir, pediatric endocrinologist from Jalgaon, to talk on fluid management in diabetic ketoacidosis. Over to you.
Am I audible?
Yes, very well.
Okay, I'll just start sharing my screen. Just let me know if the screen is visible as well.
Your screen is visible. Just try
Yes.
to make it a full
Yeah.
screen.
Right. So today's topic is fluid management in diabetic ketoacidosis. And usually we get a call from many peripheral centers when they have a child with diabetic ketoacidosis. They usually ask us and they want to send that patient to us before for management of DK. The question they commonly ask is, should I give insulin and send? So this is what probably we are going to discuss in the next 6 to 7 minutes, and what is more important in terms of management of diabetic ketoacidosis as such. Now, DKA management is probably one of the most protocolized treatment that we have available. Despite that, there are many complications that we encounter in children with DK, despite the best efforts of the clinicians to manage it. Now, commonly in developed countries, those are acute kidney injuries, hypoglycemias, and hypokalemias. And the most dreaded, but one of the rare complications, is cerebral edema. In developing countries or countries with low resource settings, usually now this percentage now increases to almost about 24 to 26%. So let us talk about how we can manage diabetic ketoacidosis as such. But before that, just have a quick glance at how the pathophysiology is. So it's basically a state of insulin deficit or deficiency and increase in the counter regulatory hormone. So insulin deficiency naturally causes lipolysis, which leads to ketosis. Now, secondly, it is also a case of counter regulatory hormone excess, which causes hyperglycemia. And then it is a case of glycosuria or glucosuria, which causes dehydration and electrolyte imbalances in the child. So now, which protocols should we use? There are many protocols in place. Traditionally, in Nelson's, we used to study the Milwaukee protocol, now which had a very rigid fluid calculation. Then came BSPD protocol, which has slightly conservative fluid therapy, restrictive fluid therapy as in terms of boluses and infusion. And the dehydration is calculated based on the biochemical or lab parameters primarily. Then came the ISPAT 2022 guidelines, which has a good conservative fluid therapy and has it's slightly more flexible in terms of management. This is slightly typed wrongly. So this is the guidelines which is now widely used throughout, and this is also shaped by one of the most influential studies in the recent times, which is the Pecan group of fluid trials. Now, which has influenced a lot of decision making and addressed a lot of gray areas in management of diabetic ketoacidosis. So diagnosis, we know it's a culmination of hyperglycemia, ketosis, and acidosis. These are some of the outliers which are mentioned. So only ketosis with acidosis, you must think of organic acidemias if the acidosis is not resolving. And then the criteria, the most important part or the difference here is the BSL is more than 200, but bicarb, which was initially the cutoff was 15, has been increased to 18 according to the latest guidelines. And of course, they have to have ketonemia, that is blood ketones more than 3 millimoles, or ketonuria more than 2 or 3 plus, or that is large ketones. So the revised bicarb criteria was initially done or probably done because there's increased sensitivity in terms of catch up or picking up of diabetic ketoacidosis cases. And now, what should you do? Venous pH or bicarb? Both of them are comparable, and both of them have good accuracy. So, what is the management of diabetic ketoacidosis? These are the three main aspects when we treat a child with diabetic ketoacidosis. That is insulin injection, then fluids, and electrolyte imbalances. But this is something that I found very informative and very concise to sum up some of the entire presentation. Insulin usually fixes the sugars, but fluids and electrolytes usually save the patient. So that forms the basis of management and fluid management of diabetic ketoacidosis. So the goals of management are very clear. It is restoring circulatory volume and dehydration correction, suppressing ketogenesis and restoring insulin action, and correction of metabolic acidosis. Now it eventually leads to restoration of normal blood glucose gradually. Correction of electrolyte imbalances is very important, and prevention of complications naturally. So this is the severity classification, which is very commonly known. However, many of us make that mistake of comparing this severity and deciding the dehydration status of the child. However, we have to look at the child clinically and look at all these signs. So if the oral mucosa is dry, CRT is slightly delayed, turgor is reduced, it's something between 5 to 10% of dehydration. And if it is severely dry and CRT is more than 3 seconds, pulses are feeble, BP is low, then probably we have to assume a dehydration status of 10%. There are certain lab criteria which can help us diagnose or understand if the child has a severe dehydration. So Any child presenting with high blood urea nitrogen that is more than 20 or pH which is less than 7.1. So the management of diabetic ketoacidosis can be summed up in this mnemonic, that is A, B, C, D, E, F, G, and I. So A for airway, breathing, and circulation. Naturally, that starts for any pediatric emergency case. Then dehydration correction, electrolyte imbalance, fluid therapy, G for GCS monitoring and blood gas monitoring, and then I for insulin therapy. So airway, of course, you have to mention, make sure that you ensure the patency of airway in altered sensorium. NG tube aspiration is something that is to be done if there is a recent history of glucose containing fluid consumption, because that will reduce or avoid sudden rise of blood glucose levels once the gastroparesis is resolved. Breathing part, O2 therapy can be given if there is hemodynamic instability, but this is very important. Avoid intubation unless it is strongly indicated. This can lead to increased CO2 and CNS acidosis. Circulation part, avoid central line and urinary catheterization as much as possible, because this is a hypercoagulable state and this can lead to increased risk of thrombosis. Now comes the part of dehydration correction. Ideally, for management of dehydration, we should try to secure two wide bore cannulas access, and the dehydration status assessment has already been discussed. Fluid bolus has to be given if there is tachycardia, not needed for mild DKS. And NS bolus of 10 ml per kg over 20 to 30 minutes can also be given. Previously, it was told that it has to be given over 1 hour, but the recent trials have shown that there is no real difference between a longer duration or shorter duration. Avoid more than 2 boluses, and total fluid bolus should be less than 40. Now, this leads to a fall of about 100 to 180 milligrams per DL of fall in blood glucose levels. Hence, starting insulin immediately can cause rapid hypoglycemia and rapid osmolar shifts. So electrolyte imbalances, sodium, we commonly see there is a low sodium at presentation, and it's usually dilutional hyponatremia. And you have to calculate corrected sodium, which is 1.6 for every BSL that is above 100. So BSL minus 100 upon 100 into 1.6 plus the observed sodium, that gives you the corrected sodium. Previous evidence showed that we had to chase the sodium values also to look for correction of decay and improvement. Now, usually the PECAN trial has shown that there is no association of falling corrected sodium with altered mental status or cerebral edema. Potassium, now usually in DK there is pseudo-normokalemia. Why is that? Because there is underestimated because of calculator, basically shift of potassium from the intracellular component. And how do you calculate corrected potassium? It's 7.3 minus pH into 0.6. So up for a pH of 7.1, it will be 1.2. That has to be added. Now, the potassium levels also decide our fluid therapy. So if it is less than 3.5, we should defer insulin initially. We should give simultaneous potassium infusion also along with hydration or bolus. Between 3.5 to 6, we have to add 40 millimoles per liter. That comes to about 10 ml of Kesol or potassium chloride and potassium phosphate in 500 ml of the pint. And above 6, usually, there is no need to add potassium to the fluids. Now, next is the most important part, that is the fluid therapy, which is the cornerstone of DK management. It is usually given over 48 to 72 hours. Now, recent trials have also shown that faster infusion rates do not actually cause harm to the child. Now, it is done by calculating fluid deficit and maintenance fluids. So, based on dehydration percentage for a 25 kg child with 5% dehydration, that amount of fluid would come out to be 1250 ml. Maintenance fluids are calculated according to Holiday Siga formula, that is 421 ml per hour, kg per hour. And for this child, if he received about 250 ml of bolus, that has to be subtracted from the total fluid that is calculated. And then it has to be divided by 47. That gives you the fluid rate, that is 87 ml per hour for this child. Now, what fluid can be used for maintenance or hydration? Any of the 0.9, 0.45 NS or RL or Hartmann solution is now permitted. Fluid rates should not exceed 2x the maintenance rates.
So sorry to interrupt.
Yes, I just the last 2-3 slides.
Yes, okay.
And it is also preferable to switch to hypotonic solution after initial 4 to 6 hours to avoid hyperchloremic metabolic acidosis. Fluid titration below above 300, do not add glucose. Between 200 to 300, you can add 5% dextrose solution. And above below 200, you can add 10% dextrose solution. to it. This is a two-bag method which is used in many institutes, which contains one 10% dextrose solution bag and one NS bag, and the fluids of both or the rates of both can be divided and titrated to make the desired percentage of the dextrose concentration. GCS monitoring, we know, has to be followed by Glasgow Coma scale, and hourly monitoring is required. Disease severity is what is important in result of cerebral edema more than the treatment itself. So earlier it was thought that it was iatrogenic. Now the current understanding tells us that it is actually the disease severity which is responsible for most of the cases of cerebral edema. What are the risk factors? Severe hypocapnia, severe acidosis, high blood urine nitrogen, and age less than 5 years. And what is the management? Giving mannitol or 3% NaCl and head end elevation, reducing the fluid rate by about 30%. And always remember, treatment first and cranial imaging later. Blood gas monitoring, you can calculate the anion gap between decade is usually 20 to 30. And it usually resolves by around 12 to 16 hours. Monitor ketones, as has been earlier also discussed. It is important to monitor the blood hydroxybutyrate or the blood ketone levels for monitoring or follow-up. Only for diagnosis, urine ketones are useful. And if there is persistent non-ketotic metabolic acidosis, look at the anion gap. If there is lactic acidosis, think of sepsis or hypophosphatemia. And if it is normal anion gap, there is hyperchloremic acidosis, then it is a benign condition. Usually avoid hypotonic fluids and use hypotonic fluids instead. And insulin therapy, we know this is not the part of presentation, but remember, always flush the tubing before starting insulin infusion. Rate of infusion both are acceptable now, and in low resource settings, you can give subcutaneous injections also. Rapid acting by about 0.15 unit per kg every 2 hourly, and short acting at about 0.13 to 0.17 unit per kg 4 hourly. These are certain don'ts which I've already discussed, but just don't give bolus rapidly. Don't start insulin infusion immediately, and don't use soda bicarb unless there is impending cardiorespiratory collapse or pH is less than 6.9. Thank you.
Thank you, sir. Excellent presentation. Hari sir, expert comment on this.
Yeah, so well presented, Ajinkya. And he actually explained almost everything. It's a huge topic to be covered in 5 to 7 minutes. Okay, and he has to speak on fluid therapy, insulin, and electrolytes. So I do not have many things to point out. Everything was covered almost. Only thing is important thing is be precise in your calculations and use one guideline.
Right. Tushar sir.
Excellent presentation. Since it was primarily restricting to IV fluids, I often see one confusion among the pediatricians that after the initial 0.45 NS or NS, when the sugars start falling and they go below 300 or 250, we add dextrose. That is done by most of us. But when after adding the dextrose in the fluid, sometimes the blood sugar start rising. So many pediatricians I have seen, they go back to non-dextrose containing. That is not to be done. In that case, we are supposed to increase the insulin infusion. So we have that provision of increasing insulin rather than removing the glucose again from the. So rather than switching back and forth between the fluids, it makes the job of the nurses very difficult. So we can instead increase the insulin later on.
Thank you, sir. So we move on with our last lecture by Dr. Sushil Yavle, sir, pediatric endocrinologist from Navi Mumbai. I would invite him to talk on approach to micropenis. Slides are visible, sir. So you are not audible.
Am I audible now?
Yes, sir.
Yeah.
Yes, you can go to full screen
as well. Okay. Sushil Devle, and today, and a very my seniors for giving me the opportunity to present in the topic among parents and pediatricians alike. We will also be discussing the approach to this of with the three clinical presentations see in this small testes is often very hard for the yet is outright ignored.
Audio is not clear.
Can you hear me now?
So there is some issue with the audio.
I'll try speaking louder. Can I now?
So you can switch off the video, so the connectivity would be much better.
You're better now?
Much better, sir. Please continue.
Continue with my presentation. So, unfortunately, in a population of 1.4 billion people, the most common concern among parents still remains whether their child in the very far, far future will be able to produce an offspring or not. And micropenis has always been a big concern among parents. Before we delve into the topic of true micropenis, let's first discuss and look at some much more commoner presentations seen in office practice. The first buried penis, which Dr. Madhura also spoke about in her topic in her presentation on obesity. So this is a normal sized penis with proximal shaft, which is buried under a pubic pad of fat and very commonly seen in obese children. Webbed penis occurs when scrotal skin extends onto the ventral aspect of the penile shaft, and trapped penis occurs when penile retraction occurs into the scrotal skin following circumcision. Chordee is nothing but curvature of the penis downward or to the side due to fibrous band of tissue. Now that the stage has been set, I will be discussing today's topic under the following subheadings, that is definitions, normative or reference data, causes and clinical pointers, investigations, and treatment. So how do you define micropenis? And are there any other terms that are often used interchangeably? So micropenis is defined as stretched penile length, that is SPL, 2.5 standard deviations below the mean for age and sexual developmental stage. In true sense, it refers to a structurally normal but abnormally small penis. The term microphallus, on the contrary, is often used when there other conditions coexist, such as hypospadias, incompletely fused scrotum, or non-palpable or undescended testes, which are often seen in conditions such as DSD or difference in sex development. Micropenis is a clinical finding. Much like the classic example of jaundice, we need to remember it is not a disorder. Thus, we need to determine the etiology, which will help guide management. Now, where do we plot this? We saw that it is defined as 2.5 standard deviations below the mean. But where do we plot this? Are there any normative or reference data available? The answer to that is yes. There are global country-specific data available with mean stretched penile length numbers given for birth and various other ages after that. Although there can always be an element of ethnic specific variation among these data, there are also multiple Indian studies reported on stretched penile length, as you can see in the literature. Of note is the study by Dr. Vaman Khadilkar sir and his group, performed on children and adolescents from Western Maharashtra. And they give a mean SPL at birth of 4.1 plus minus 0.4 centimeter. And their growth charts are very easily available. As you can see, there's a red line in that chart. So any child between 0 and 18 years of age with a stretched penile length that falls below that red line can be classified or categorized to have true micropenis. Some important take-home cutoffs to remember, which are the numbers 2 and 4. That is, a stretched penile length below 2 centimeters at birth or below 4 centimeters at 5 years of age or any time after that are absolute red flags, and this child needs to be referred to the pediatric endocrinologist. Coming to causes and clinical pointers, so it can be divided into three broad categories. If the defect is at the hypothalamic or pituitary level, it is because of hypogonadotropic hypogonadism. Commonly, conditions such as Kallmann syndrome, where anosmia coexists, certain syndromic conditions such as Prader-Willi syndrome or Bardet-Biedl syndrome. If the defect is at the gonadal level, it can be hypergonadotropic hypogonadism, conditions such as anorchia or vanishing testes, testosterone biosynthesis defects such as 5-alpha reductase deficiency, partial androgen insensitivity syndrome, chromosomal or genetic syndromes such as Klinefelter, Noonan, or Down syndrome, and partial gonadal dysgenesis. And of course, there's miscellaneous such as penile agenesis or exposure to endocrine disturbing chemicals such as pesticides and flutamide during the intrauterine period. Like most other clinical conditions, when we do not find a diagnosis, a cause for the condition, the magic rescue word comes into place, that is idiopathic micropenis. And coming to clinical cues, so on history, if there is history of anosmia, that points to something like Kallmann syndrome. Consanguinity is important for autosomal recessive disorders such as LH receptor gene mutations. Breech delivery, very important in growth hormone deficiency. Prolonged neonatal jaundice or hypoglycemia, again important in either isolated GHD or multiple pituitary hormone deficiency. On examination, if the child is short, obese with hypotonia and almond-shaped eyes, it is Prader-Willi syndrome. If the child is short, again, obese with polydactyly, retinitis pigmentosa, it is Lauren-Moon-Bardet-Biedl syndrome. If the child is short, again, with midfacial hypoplasia, midline defects, central obesity, cleft lip, it can now be something like a growth hormone deficiency. If the child, on the contrary, is tall with gynecomastia, firm testes, it is Klinefelter syndrome. Micropenis with absent testes is vanishing testes syndrome. If the child presents with vomiting, dehydration, failure to thrive, hyperpigmentation, it could be because of CAH46XX or 46XY, wherein there are testosterone biosynthesis defects. And if there is marked virilization at puberty, it is because of 5-alpha reductase deficiency. So how do you measure stretched penile length? Remember, it has to be measured in flaccid state, ideally in standing position. The glans has to be held between the thumb and index finger. A firm ruler or a spatula is pressed against the pubic ramus to retract the pubic pad of fat. And the penis is measured till the tip of the glans. Remember, we have to exclude the foreskin while measuring stretched penile length. Now, investigations. They mainly help confirm clinical suspicion. But before we go on to investigate the child, the most important and powerful tool readily available at every pediatrician's clinic is the IAP 5 to 18 and the WHO 0 to 5 growth chart. And as you can see, height, weight, BMI, if plotted on these charts, definitely help us narrow down the differentials of micropenis. Now, not many of us know about this, but mini puberty, seen between 1 and 6 months of age in boys. This is the time wherein the hypothalamo-gonadotropic HPG axis is very active in children, and it provides an excellent window of opportunity to test this HPG axis and to establish the level of defect, as we discussed, if the level defect is at the hypothalamic pituitary level or at the gonadal level. So what tests can be performed in biochemistry? Very important is karyotype, especially at birth when the gender has not yet been assigned. SRY gene by RT-PCR has a very rapid turnover time of just 4 to 5 hours and is now being commonly used to confirm the presence of Y chromosome.
So sorry to interrupt.
Yes.
We are running out of time.
Yeah, just another 2-3 minutes and I'll be done.
Yes.
LH-FSH testosterone and dihydrotestosterone, basal and stimulated, should be performed. 17-hydroxyprogesterone and other anterior pituitary testing if MPHD is suspected. In imaging, ultrasound of the pelvis to confirm size and position of the testes, and also to confirm absence of Mullerian structures. an MRI brain in case of hypogonadotropic hypogonadism, and SOS and MRI abdomen can be performed to locate testes if not seen. Genetics is ideally done to confirm the diagnosis. Stimulation tests such as GnRH stimulation test and HCG stimulation test are more complicated, and in the interest of time, I won't speak on this in this presentation. Just a simple flow chart to remember, and three things I would urge the pediatrician to do is: number one, as I spoke about, is to confirm the karyotype. If it is 46XX, we points more towards a diagnosis of a CAH, where it is the child is significantly virilized and the genital tubercle is showing as micropenis. If it is 46XY, then see if any other DSD presentation, such as a hypospadias or undescended testes, coexist, or if there are any syndromic associations. And number three, to test for the basal and stimulated values of LH, FSH, testosterone, and dihydrotestosterone. And this is a screenshot worthy slide if you would wish to do that. Based on that, there's a very simple algorithm in which it could be either an isolated anatomical defect. If all are low, it can be congenital hypogonadotropic hypogonadism. If all are high, it can be either partial androgen insensitivity or 5-alpha reductase deficiency. And if the gonadotropins are high, but the testosterone is low, it will be gonadal dysgenesis or testis regression or testosterone biosynthesis defects. Now, why do we need to treat? The main aim of treatment is to attain a penile length which is sufficient for urination and sexual function. And it also provides means to assess testosterone responsiveness in the newborn. So what treatment choices are available? They are in the form of testosterone, which is a short 3-month course of intramuscular 25 milligram testosterone. Remember that doubling of the stretched penile length equates to a good response. DHT gel is used in conditions such as partial androgen insensitivity and 5-alpha reductase. Remember, care must be taken while applying this cream, as they have a very sensitive absorption, and a female, if applying, can show signs of virilization. Growth hormone alone in isolated growth hormone deficiency helps in increment of penile length in children, and they do not need testosterone or DHT. HCG and recombinant FSH has been tried and has been seen as up and coming treatment for children with congenital hypogonadotropic hypogonadism. And surgery has very limited role. Penile reconstructive surgery has been mentioned in the literature, but such complicated procedures can be performed only in adulthood. The key takeaways from today's presentation would be to confirm true micropenis and rule out the much more commoner micropenis mimics, measure properly, and plot on SPL charts, which are widely and easily available. Use IAP and WHO growth charts for narrowing down the differentials. Always remember mini puberty. And if everything fails, remember you can always refer to the pediatric endocrinologist, to us. And as my mentor, Dr. Maman Khadkar sir, always used to say, pen is mightier than the sword. However, we fail to understand the importance of the gap between the words pen and is. Thank you.
Excellent presentation, Dr. Sushil. I request Hari sir for expert comments.
It was an excellent presentation. Every aspect was covered in this presentation. So, what I wanted to say was there in takeaways. Just to rule out, we'll see most of the kids with obesity having this coming with micropenis, but they usually have buried penis. So, the actual way of measuring it, the pressing the suprapubic fat and actually measuring it, is the most important technique to rule that out. And presence of chordae and other things, as Sushil has pointed out, very excellent. So just measure it, and then you can use that chart to find out whether it is really micropenis.
Tushar sir.
Very well said, Hari. Excellent presentation by Sushil. And to add to whatever has already been discussed, one is many times pediatricians reassure the parents कि बाद में बढ़ जाएगा, puberty में देखेंगे, and we often miss the mini puberty window. So अगर mini puberty में we are seeing the patient, it's best to investigate that time. But if we have missed the mini puberty, then probably at 12 years, we again get the window. Doing testosterone levels for a child who is in his pre-pubertal years is waste of money and time, because the testosterone value is going to come very, very low. So either do the hormonal testing in mini puberty or probably after 12 years, not in between. Thank you.
Thank you.
Thank you, sir. Excellent presentation, Dr. Sushil. So with this, I would like to thank our experts, Dr. Hari sir, Dr. Tushar sir, for guiding us throughout. I would also like to thank our speakers, Dr. Tejas, Dr. Bhushan, Dr. Madhura, Dr. Ajinkya, and Dr. Sushil for this excellent presentation of yours. I would also like to thank my friend, Dr. Yash, for being the moderator, Minaj sir, Amol Pawar sir, Sanjay Pakmode sir, for giving us this opportunity to come ahead and have this session. Thank you all. So we can close the meeting.
Thank you.
Thank you.
Bye all. Happy night.
Thank you all. Wish you happy Diwali.
Wishing you all a very happy Diwali and a prosperous.